From a disclosure standpoint, I am on the board of the GFPD, and I sit on an independent data safety monitoring committee for Eli Lilly drug study, but I don't intend to discuss that at all today. And Dr. Vandervoort has no disclosures to make. From an objective standpoint, I'll go through these pretty quickly, but we do want to touch on the overview of palliative care, the difference between hospice and palliative care, some common symptoms encountered here, and some potential treatments that palliative care can offer. And then Dr. Vandervoort is going to really talk about concurrent care and what that can mean for families, and then leave some time for questions and answers at the end. I am going to cover this pretty quickly, mainly because I want to make sure that we have time for questions at the end. Really wanted to highlight this because I think that this talks about your families and that the wide array of symptoms that we see, which means that not one approach to symptoms, to treatment, to support is going to fit any one child, because it's going to be as unique and individualized as each child. And that's because they all fit on a different spectrum, and getting to know a family and getting to know a child is what's going to help us be the most efficient as a palliative care team. So to kick us off, the difference between palliative care and hospice. The thing we hear the most from families is when they hear palliative care, they hear hospice, and they equate the two. And instead of it being something that's the same, there's definitely an overlay, and hospice is part of palliative care, and end-of-life care is. But palliative care is so much more than that. It really, we advocate for it to be at any stage of the disease, and ideally at the time of diagnosis. We are able to get to know a family and a child and the goals and the things that are important to that family and how that may change, that trajectory may change over time. So much better if we know you from the beginning. Not that we can't be involved later on in a disease process, but the earlier we're involved, if we know the trajectory could be life-limiting, is really helpful for us. Palliative care is right alongside other therapies for a disease, and is often intermittent visits. Hospice is more comfort focused and is more end-of-life focused. But the biggest overlap is that the focus is on relief of symptoms and prioritizing the goals of the child and the family. This is a good little graphic for how palliative care and curative or disease-directed care can overlap. So really at this diagnosis point, you can see palliative care can be involved, and how involved we are is going to be dependent upon what the patient needs. But as we step up our symptom-directed care and maybe step down disease therapy care, there can be just kind of that overlap, that natural transition that may happen over time. And then the end-of-life care and hospice is obviously a part of what palliative care does. But then the other thing is we don't go anywhere. Bereavement care is another piece of palliative care and hospice care that comes along with this therapy. So it's important to remember that we are involved through that whole trajectory. I think this is kind of an important graphic because it can talk about who and when palliative care can be helpful, because depending upon the disease process, there's a different arc that families go on. The vast majority of families with peroxisomal disorders is going to be right here in this corner, where they're going to have a baseline health status and they're going to have these intermittent crises. And we are there kind of through them, where they are during a crisis period, but also when we reestablish a new baseline, and not knowing how that trajectory will look over time, but it's intermittent and changes for each different patient. A couple studies that I wanted to highlight. I really like this one. This is from 2013. It's an observational study of 6 families, and they're caring for a child with a progressive neurodegenerative disease. So much of the pediatric palliative care literature really focuses on, children with cancer or trauma, so a neurodegenerative illness was a unique paper. They did such a great job of describing a lot of the things that happen in a family throughout this. They talked about this how do you hold this predictability of the days, but then the unpredictability of what the future holds, and the fear that is accompanied with that, and how particularly that fear is heightened in the early days of diagnosis and then again closer to the end of life. It pointed out the exhaustion that's experienced by families, but then it really, in this great way, highlighted this transition that so many families experience, where they're able to kind of hold on to that uncertainty on one side, but treasure the moments that they're there for right then. And that quality and length are not always equal. and then showed that these families over time began to trust themselves, began to trust that they knew what they knew their child and knew what their child needed and were able to advocate for that. And that's where we really see palliative care and what palliative care teams everywhere, their goal is to stand in and help you be an advocate for your child, to know the ups and downs and those different things. The other thing that I really appreciated was how they described it as a chronic sorrow, because there is this ongoing sense of loss, whether it's today your child can't do what they could do last month, or just knowing that what the future is unknown, and that chronic sorrow that comes along with it, and how that can wear on not just, the primary caregivers, but siblings and kind of those secondary impacts. This is another study with just kind of talking with challenges of palliative care in children with inborn metabolic diseases. It highlighted 30 families over 3 years. It highlighted some of their primary symptoms, which I think many of you are familiar with: GI, respiratory, and neurologic symptoms. All of these have certain therapies that palliative care can offer to direct specifically for those symptoms to help those and improve quality of life. It highlighted the uncertain trajectory of each of these children, but of these 30 families at the end of 3 years, more than half were still alive at the end of that 3-year period, but we're having palliative care interventions early on. I also talked about the advanced care planning discussions that were had with families by the palliative care teams, and that it is unique and different for each family. And just because you're involved with palliative care doesn't mean you have to limit resuscitation. More than a third desire a full code for their child. The other thing is they didn't just have it be a full code or no code. They really talked about how there could be unique things that you want for your child and have specific limitations. Like, I want them bagged but not intubated, or I want them intubated but not trached. And how every family, that's different based on what their child needs, and how a palliative care team can help navigate some of those nuances. And this is from Femke, also from the GFPD. And I think that's really important when we think about these children and also some young adults and adults living with this disease. So we don't always know at diagnosis what their symptoms are going to be and what their disease severity is going to be. Sometimes the exact mutation can help highlight that. We know there's going to be some things that are shared among these children with, the hearing deficits, the ocular abnormalities, the enamel abnormalities up here at the top of the slide. But then some of these symptoms can come on at different points in life. And it's really important that a palliative care team, a primary care team, is aware of what may be on the horizon for your child, to kind of try to anticipate it and plan for some of those things as they come along. And in that same vein, I have essentially just another slide showing the different symptoms that children can have, and then when they could present, and being able to address them as they come up, but also plan for them. And I think the other thing that palliative care is really important for is helping a family prepare for what could happen. Sometimes that's in the hospice and end of life scenario, and saying how that could look and making sure a family has all the preparation. But it can also be with, well, in 6 months, we're going to start screening for this because this is something we're looking for, and things of that nature. With that, I've kind of touched on my side of palliative care and hospice and some of symptom management, but I want to turn it over to Dr. Vanderford so she can talk about hospice and concurrent care.
Thank you so much for the invitation to speak with you all. Looking forward to your questions later on. And please reach out in the chat if there are things that come up as we're chatting. So as Dr. Draper mentioned, there are a lot of similarities between palliative care and hospice. And palliative care physicians are oftentimes very involved in children enrolling in hospice. Both tend to focus on quality of life and comfort. And for most families, that means being home as much as possible. So this makes home hospice usually an attractive option, but one that previously required considering giving up some life-prolonging therapies that had been ongoing. However, palliative care and hospice are distinct entities. Both have a goal of supporting families and patients living with serious illness from a physical, emotional, and spiritual standpoint. Palliative care provides support for kids and families living with serious illness at all ages and all stages of illness. So as Dr. Draper said, getting involved early on, even at diagnosis, is really helpful. We hope to get involved early, so we have the opportunity to get to know the patient and the family, and over time to be able to explore values and goals, to develop a close relationship, develop trust, so that down the road, if there are difficult decisions to make, that we can have some really just frank discussions based on what we know about you and your family. Hospice is a service available only when life expectancy is less than 6 months and is generally provided by home health care companies contracted through Medicaid and insurance companies. They're paid on a daily basis, a per day basis, to cover the patient's medical care needs, and including physicians, home nursing visits, and medications for comfort. Things that hospice do not consider comfort focused previously had to be paid for out of pocket. So families previously were often forced to make a choice about having access to home hospice to be able to keep their child at home, or whether to continue to provide life-prolonging therapies that they really felt were beneficial and they wanted to continue. So with a goal of keeping patients at home, most hospice care is provided in the home. But if in situations where comfort cannot be maintained or achieved at home, it is sometimes provided in the hospital or other care facilities. And one thing I didn't note on the slide is that decisions to enroll in hospice are revocable. So in a situation where you decide to enroll in hospice and you find that it really isn't helpful, it isn't what you anticipated, you can change your mind at any point and then possibly re-enroll later. So it's not a one-time, it's not a permanent change. So fortunately, the Affordable Care Act of 2010 lifted restrictions on access to life-prolonging and curative therapies for kids in hospice. So this was a real game changer. So kids can be enrolled in hospice with a goal of being home as much as possible, and yet continue their other previously covered therapies. They can be admitted to the hospital, they can see their primary care provider, and at the same time receive those home hospice services. So note that this concurrent care amendment to the Social Security Act is a federal mandate, and it's for those children receiving hospice through Medicaid or CHIP or the Children's Health Insurance Plan. So while some private insurers may provide similar benefits, others do not. So if you do have private insurance, it's important to check your coverage if you may be interested in accessing this program down the line. So in other words, for the patient who's thought to be within the last 6 months of life, they may choose to enroll in hospice services without the loss of any current care the patient or the family wishes to continue. And this may even include clinical trials that the patient may be eligible for. And I'd like to just point out that I use the phrase thought to be in the last 6 months of life, because there are many, many patients who remain on hospice far greater than 6 months. Our ability to prognosticate is not always good. I think Dr. Draper showed a slide that said something like 50% of patients were alive at 3 years beyond what may have been anticipated. So we're not always great at making a good prediction of unfortunately when life may end. So fortunately, patients survive a lot longer than often we anticipate. So what happens at each hospice recertification period, the doctor's prognosis is again sought, and the eligibility of the patient is reviewed. And if the physician at that point still thinks that the risk of dying within the next 6 months, if the disease process follows its usual course, then that patient remains hospice eligible. So that's why we sometimes have kids on hospice for years rather than just the 6 months that we're saying here. So services generally and historically provided by hospice are billed to the hospice. For example, medications for pain or medicines for shortness of breath. And the hospice is paid a daily rate to provide these and to provide home nurses, home visits, Services outside of these usual hospice care, such as transfusion or potentially BiPAP therapies, are then billed to Medicaid via a more standard billing process. Sometimes it's not clear where that service falls, whether it would be under the hospice bucket or standard therapy billing. It's really up to the state Medicaid office to communicate with the hospice and the various service providers to kind of sort this out. So for example, a child who has advanced cerebral adrenoleukodystrophy may have his comfort medications, such as morphine, paid for by the hospice, and his neurology, pulmonology visits, anticonvulsants, and maybe CPAP paid for by under standard billing. It is pretty complicated, and it's complicated in part because states have certain mandates of things that they have to cover. There are things that are optional, and the states get to decide how they're going to implement the Medicaid benefits. They may choose a fee-for-service model or contract with a managed care company. So given the diversity and the complexity, I would really encourage you to explore how these services are provided in your area before you need them. And this would be especially important if you have current access to home-based nursing through an optional Medicaid waiver program, just to assure that you won't lose those services if you enroll in hospice. Some of the optional waivers may not be guaranteed with concurrent care. So just important to explore those things before you need them. And also consider if you're making an insurance change potentially related to a change in your job and you have a choice of various private insurance companies, you may want to check in their benefits to see if they offer concurrent care with hospice, because that may be a consideration that you want to take into account when making your decision. So this is just an amazing resource when it comes to concurrent care. It's one of the most comprehensive that I've seen. So if you have more questions, I would encourage you to explore this resource. And they also have great resources on other things, all related to hospice and palliative care. So again, just thank you so much for allowing us to chat with you today, and we welcome your questions.
One thing came to my mind as you were talking, Dr. Vanderford, is that one thing we didn't mention about palliative care teams is first the team approach. You know, both of us are physicians, but we work on a team with nurse practitioners, with social workers, with RNs. We don't just support families just in symptoms, but also in many other elements of life. And the same thing with hospice companies. Many times there are, you know, art therapists, pet therapists, there's all these other kind of supported services that can help with symptoms and with the entire grief process. So if this is something that you're exploring, those are questions to ask. What about the other supportive care services that come along with both the palliative care team, which may be home-based at a, you know, kind of your medical home and a tertiary medical center, versus hospice, which may be in your community that could be further from your home. But those are important questions to ask as you start this process.
Thanks so much to both of you. And yeah, no problem. Jump in anytime and share. We're grateful to have you both here sharing your expertise on this important topic. We do have one question, and it looks like we have a professional that's in our audience who is looking to explain this option to families with school-age children. So do you have any suggestions for how to approach a family and start this discussion?
I'll answer quickly and see what Dr. Vanderford does. You know, I think about a lot of my primary patients are oncology patients. My biggest piece of advice is talking about it as soon as you have a diagnosis that may potentially go down this path. So if you have a life-threatening or a life-limiting condition, I think that mentioning it early on. So even with a child with like a new diagnosis of leukemia that's anticipated to be cured, I always say you're going to get to meet our palliative care team so that we can make sure that we're taking care of symptoms in your family and addressing all of those issues from the very beginning. And that kind of can help normalize it. If it has been some time, I generally use the phrase of, you know, when I see your child and knowing them for the time that I have, it seems like we're having more problems, more admissions, more doctor's visits than we did 6 months ago. I want to make sure that we're taking care of the things that are most important to your family, and a palliative care team can be very helpful in helping assess the needs and all of the supports you may need. So that's how I introduce it. I don't know, Paula, if you have other phrasing or best ways that you think.
I like your idea of normalizing it, just that for that child to know that this team sees all of the patients who come through this clinic or who have this diagnosis, and to really emphasize the various ways that we can help in terms of communication and continuity. I think one of the things I would emphasize is just making sure that the medical team is seeing them as a person, and rather than a symptom, or you're having issues with your seizures, that we're somebody that tries to just pull everything together and see them as a family, normalizing it, describing it, the ways that we can help. Yeah, I think those are the key things.
Thank you both so much. I couldn't agree more. I think when it comes to rare disease, we can say we need to normalize a lot of conversations surrounding rare disease. And I think your advice just now, Dr. Vanderford, speaks to any healthcare settings, any environment, when you're working with a team of doctors, making sure that they're seeing you as a person and as a family unit. So thank you for sharing that. We do have a question kind of very similar, but from the family perspective. We're interested in palliative care and want to begin that conversation with our primary care physician. Then how should we approach that with our family doctor, our pediatrician?
As a physician, I'm always distressed that a family would have to be the first one to bring it up, because I feel like it's our responsibility. But I appreciate that you all are the best advocates for your children. So I think the biggest question is whoever you identify as whether that's your neurologist, your pediatrician, your primary care provider, as kind of the captain of your medical team right now. I would probably start there and say, we would like an additional layer of support. We've heard that a palliative care team can be helpful. And then say, and how can we get that here? Because it is going to be unique based on where you are, where your primary medical care is. And then we were even talking about it before the webinar started, like what can we do virtually versus what can we do if you're traveling into a larger medical center versus what can we do locally within your home. And some of that's going to have to be navigated by your pediatrician or by your primary care provider there. We get calls not infrequently to the Footprints office at Glennon that was like, we have this family that's, a couple hours away. This is a situation. What can we do? And then we have to work through what's going to be best for that family. But I think just in the same way, we should be normalizing it with families, normalizing it with whoever's your captain of the medical team would be my suggestion.
Thank you. And Dr. Vanderford, did you want to add anything?
I think approaching it with a curiosity, to ask your provider what their experience has been with palliative care within the community, who they would recommend, and then to bring it up as an addition to their team, that you appreciate so much all that the current team is doing, and that you think that the addition of the palliative care team and we are an addition. We don't take the place of any other physician or clinician or provider currently present. So in addition to the things that Lauren had stated, just being curious about how they see the palliative care team kind of integrating and helping with continuity and care coordination as well.
Thank you. I just wanted to address a few questions that came in about, is this disease curable? And I wanted to just answer that and acknowledge that we do see these few questions coming in, and that this disease, peroxisomal disorders, that the GFPD provides support, advocacy, and research for. At this time, there is no cure. There are supports and symptomatic treatments in place. There was a question that followed this about, doctors are insisting that the age of survival is 3 years. And I think maybe Dr. Draper, as one of our medical and scientific advisors with the GFPD, may be able to speak to that about the spectrum and the survival rates varying.
The spectrum is from infancy to adulthood. And you can't always predict who's going to fall in what category. And I continue to be surprised by children on a near daily basis that do more than people told their parents they would do when they were first diagnosed. So I think that you should reach out to the GFPD and we can help get you in contact with some medical experts that are happy to even work with your team and try to help direct some resources, because I think that's one of the many struggles with rare diseases is that you may struggle to find a physician that has ever taken care of a child with the same diagnosis or a patient with the same diagnosis. And then what they're doing is they're reading textbooks, and textbooks are slow to update. But our experience is that these patients can live a very long time, and that spectrum is widely variable. And that's why each patient needs to be treated as an individual patient within their own family unit.
Thank you so much. That was such a great answer. And absolutely, please reach out to the GFPD on our website. There's a contact us button. My information is easily accessible as well. My first name, Katie, at thegfpd.org. I am happy to facilitate and make sure that you get to the right people that can help you. I think we have time for one more question. And that would be regarding caregiver burnout, which I believe also, Dr. Draper, again, this is something that in your bio even I saw is something you're passionate about. And they're wondering how palliative care can assist with addressing the caregiver burnout.
I think that's such an important topic. Families, it's something you never knew that you would need to know how to do. And you don't know how, there's no guidebook. And I feel like in the middle of everything, it's trauma. It's like that just keep swimming mentality, but you can only just keep swimming for so long. And that's where I really feel that our palliative care teams, knowing the family, I mean, there are times that, literally one of the nurses on the Footprints team will come and be like, Mom is not in a good spot. We're going to need to figure out, and it may be time for a respite admission because Mom needs a few days of respite, or she's got to go to this job interview, or Dad can't do this, or, all of these sort of things, or siblings have something special and we need to figure out a way to support the family. And that's where really knowing the family and knowing where some of those additional stressors can add to that burnout, but also can help navigate the complexity of care and care coordination, because sometimes burnout is not from the actual care. Those are the things that we provide for our children and are meant to do. It's the phone calls, the organizing appointments. It's those other pieces, those extras that can add on top, and being aware that they happen. But that's where the other supportive services from a palliative care team can really come into play to help decrease some of those symptoms of burnout, or at least acknowledge them and normalize them again. Dr. Vanderford, do you have other thoughts on that?
I think one of the ways that we can help in terms of continuity is to be able to pass on to maybe newer providers what conversations have been had, what the family's understanding is. One of the things that I think I hear is families talk about, being asked over and over again about, is this really what you want? We could do this, or we could do this option, or we could do this option. And for them to just have to go through conversations over and over again, feeling like their decisions are being potentially questioned. So if the palliative care team is involved, sometimes we can have conversations with providers and say, yes, the family understand, this is their understanding of the illness. Please confirm that with them. But, we've had many discussions about this, and these are their goals and preferences, at this point. So I think that's one way. And then while we can't fix necessarily the problem, we would love to be able to fix things, but oftentimes, just being heard and to know that you're not alone, and to have someone to listen, and as Dr. Draper said, normalize what they're experiencing can be helpful. So you do have resources, and we hope that folks will reach out so that we can try and help.
Dr. Vanderford, actually, just to carry over that continuing care, is there a difference in the care provided between, we've talked a lot about children and pediatrics. We have quite a few adults, including my own son, who's living in his 20s with this rare disease. Is there any difference that you see in the care that's provided for adult patients? We have a question that came in from someone I know who has someone actually who's older than my son that's living with peroxisomal disorder.
There should not be. There's nothing magic about the age of 21. I find it painful that patients lose services at 21 or that they're treated differently because they've crossed a threshold of an age. So hopefully that there are more and more providers who are straddling that transition period from young adolescents, young adults, to help provide more continuity of care. We're also trying to build a transitional care program where Dr. Draper and I practice. Unfortunately, the concurrent care stops at 21. And so I've had families decide not to go into hospice because as much as they would love the home healthcare assistance, that they would lose they would have to come off of some of the anticonvulsants that they're on because they're more expensive than the hospice is willing to cover. So unfortunately, there is a difference, and I certainly wish there was not.
I agree. Thank you. So we did have a question come in that I just want to share. We will address afterwards and follow up. So if you've asked some questions and maybe not heard from us live during this webinar, know that I do have your information and I will follow up with you. There was a question about palliative care for refugees from other countries. And I've already spoken with Dr. Vanderford and Draper about, following up with you, and we will make sure that that information is shared. We also have one last one, and I said we had that last one, but I think this is a great one to end with. So if you don't mind, we so appreciate you both being here with us. Could you share briefly, what does success look like from a palliative care perspective?
I love that question. Success is defined by the family. One of my favorite questions to get to know a family and also to get to know what is important to each patient is, what does a good day look like? Because what a good day looks like for me and for my children is going to be very different than anybody else on the street, and only I can define that. And I think that's the same thing with all of my families. So it is one of my favorite questions, and how you define a good day is going to be how I define success in palliative care. How can we get you more of those? And it may not even be a whole day. How can I get you more hours that look like that rather than fewer? And that is likely going to change over time. And that's where I think we do periodic check-ins to really have some of those high-level, big picture discussions about it. That's how I define success in palliative care. But Dr. Vanderford, what do you think?
I love the more good days kind of measuring stick. That's really good. I think that I feel the most successful when I've really built a strong and trusting relationship with a family and felt like I've gotten an understanding of what's important to them, so that when those hard decisions, if those hard decisions do come, that hopefully looking back, that family is not going to have regrets. We may not get the outcome that we would all hope for, but to feel like I've helped them make decisions that 20 years, 30 years down the line that they're going to be able to feel good about. So for me, that feels like success.
Thank you, both of you. Dr. Vanderford, Dr. Draper, we appreciate you both being here, sharing your expertise, reminding all of us families that, we need to be seen as a person, as a family unit, and we deserve for the collaboration to happen. And you just really shared some great advice and suggestions for our families moving forward that may be interested now or later in palliative care. So we really appreciate you both being here. To our audience, thank you for participating, all of the wonderful questions that have been submitted. There have also been a few thank yous as well from our audience that have come through with their questions to both of you. And we do ask that everyone take a moment to complete the survey after this webinar. And thank you again. And I hope everyone has a wonderful day.